Hello and welcome. We're going to start with our second module in the P&T Competition Skills webinar series. This time, we are going to be focusing on grading the evidence and the evidence pyramid. My name is Kristen Patty, and this is part 2 of 5. So last time we spoke about methodology and references. This time we're going to talk about what do you do with all of those references? How do you assess them? Where do they fall in that pyramid? And how do you decide going forward if these are worthy of your discussion and inclusion in the monograph or presentation? So this information, how you grade the evidence, again, will be important for both monograph and PowerPoint. It should be both informing your literature searching methodology as well as helping you decide which studies should be included or excluded from your final presentation. We see a lot of students do a good job of grading their randomized control trials. What we want to make sure students are doing is also performing that same critical analysis of systematic reviews and meta-analyses in particular, as that particularly seems to get missed. As you're grading your evidence, keep in mind that that evidence pyramid is key. You can't grade the evidence without knowing what kind of evidence you have. And placebo-controlled trials are the bare minimum. They are not the only type of evidence you should be looking at. They are definitely not the gold standard of evidence in terms of your final evaluation. They are one component of your complete clinical summary. So we're going to start with the evidence pyramid, which we did introduce in section 1, but we'll go into a little more detail. So this evidence pyramid is designed to help you consider the different types of clinical information you may encounter as you're doing a lit search and as you're writing your summaries. You'll see at the bottom of the pyramid, there are more qualitative types of summaries. So things like expert opinion, case series reports, cross-sectional studies, and case control studies. As we get further up the rung, we run into things like cohort studies, randomized controlled trials, and then the pinnacle would be our systematic reviews and meta-analyses. As we get towards the top of the evidence pyramid, we find fewer and fewer results, but these tend to be our higher quality types of evidence. So wherein some of our low quality expert opinion may be more observational or narrative, we're getting more quantitative or numerical data when we talk about RCTs and systematic reviews. So when I talk about qualitative versus quantitative, a couple of things to keep in mind when you're looking at different types of clinical evidence. Qualitative evidence is going to be things that are expressed in words. So these could be focus groups or interviews or narrative summaries. These tend to be lower quality evidence, so towards the bottom of our pyramid, and they can be more subjective. Quantitative evidence, on the other hand, is things that are expressed in numbers. So this is where you're testing a hypothesis. You have a statistical analysis that's been performed, and these are generally higher quality evidence. This provides you with objective information about whatever research question it is you're investigating. So in addition to talking about high and low quality types of evidence, we wanted to summarize for you some advantages and disadvantages of different types of studies. On the next 2 slides, we've broken down the 6 major study types along with some pros and cons of each. So starting with our cohort study, case control study, and case report study, there are many, many pros to using these types of evidence, albeit they're lower on our evidence pyramid. I'm not going to go through each of these bullets in detail. I would encourage you to pause and review on your own time. But broadly, these types of evidence have some benefits in that they can bring our awareness to really rare events or things that we would not see in a limited or highly controlled clinical trial setting. These types of studies also tend to give us longer term information or information you can't get from a clinical trial, such as what happens with an exposure that you would not intentionally expose a patient to. On the flip side, these types of studies, because they are so qualitative and uncontrolled, can be more prone to confounding and bias. And so we have to interpret these results really with more of a hypothesis generating or informational mindset. Things from these studies should be further investigated in a smartly designed RCT. Now, on the flip side, when we talk about meta-analyses and systematic reviews, these really are built on that randomized control trial. So randomized control trial are often the focus of our P&T competition summaries, and for good reason. These are the basis of FDA approval for these drugs and are often some of the best evidence we may have available at the time of initial approval. That said, what we would love to see is a focus on not just that RCT, but also the evidence that can come from multiple RCTs. So RCTs serve as the foundation for your meta-analyses and systematic reviews, where they're aggregating data from multiple studies. Meta-analyses do this in a quantitative manner. So again, taking all of those studies, combining them numerically, and increasing the statistical power of that overall assessment by pooling the data. Systematic reviews are similar, but done in more of a narrative approach. So we're combining all of those studies. We're looking for trends, we're looking for differences, but we're not doing a hypothesis testing. And one last caveat I want to throw out. So when we talk about meta-analyses and systematic reviews themselves, again, I want to encourage students to make sure that we're specifically critiquing these, as that sometimes gets missed. But keep in mind that either of these can be only as good as the studies that they are built upon. So if you have a bunch of low quality clinical trials that have been conducted and then they get written up into a meta-analysis, that's going to limit the quality of your meta-analysis. And that's just worth keeping in mind when you interpret the results from that MA. All right, so grading the evidence. Why is it important to grade our evidence? So as I've kind of alluded to, the decisions we make, or say the recommendations your P&T committee is going to consider, are only as good as the data they're based on. So you have to determine when you are reviewing the data if it is worth including in your write-up. We want to make decisions that are evidence-based, based on high-quality data. Doing so helps us improve patient outcomes by ensuring we are preferring safe, effective, and evidence-based options. But we have to be a little wary that the data we get may not always be as high quality as we would like. And so we're going to talk about the grade system briefly, which is just one option that helps you evaluate the quality of those recommendations and the certainty of evidence upon which those recs are based. So GRADE, or GRADE, all caps, is a specific system. There are different tools that can be used, but this specific system starts from the basis of assuming that RCTs are higher quality because they are based on that quantitative evidence, whereas observational data starts as a lower quality. The grade system then further breaks those assumptions into high, moderate, low, and very low quality. And you'll see how even once you start as an RCT, you can move up or down this scale based on different factors. And if you start as a lower quality, you may have the opportunity to move up if you have factors that favor your evidence being higher quality. So we'll talk through some of those factors now. Factors that can lower the quality of evidence. So if you're looking at a trial and it looks fantastic, a few things you'll want to look out for that may lower the quality of that evidence include a risk of bias, imprecision or indirectness, inconsistency, and publication bias. So the risk of bias, the way you'll want to assess this, and particularly in a randomized trial, a few things you'll want to look out for are a poorly designed randomization process. When you're reading either the final publication or the full clinical trial protocol, you can learn more about how they randomized patients in the trial. And you want to look for a more complex system that ensures blinding, ensures equal assignment of patients into groups. That said, you'll also want to check on the blinding and see if there was either no blinding or there was a risk that patients become unblinded and become aware of which group they are in. You'll want to look for study attrition or loss to follow-up, and then selected outcome reporting, because both of these can favor one outcome or the other. If, say, all the patients who had a negative reaction to your drug dropped out of the trial and their outcomes were not included, that may make the product look more favorable than it actually is. When we're looking at inconsistency, there's a couple different things we're looking for. So for narrative data specifically, we're looking for conflicting results. So either some evidence is showing benefit while others shows harm, or there's inconsistency in the amount of benefit seen. So differences in effect size per se, where maybe one study shows a 20% improvement in LDL, and another study shows only a 1 or 2% improvement in LDL. Both could be considered positive, but they have very large differences in that effect size. When you're looking specifically at a meta-analysis, you'll want to pay close attention to the effect estimates. And so you can check for specifically your confidence interval and if there's any confidence interval overlap. You may also want to educate yourself and learn about the statistical tests that can be used to assess heterogeneity and if that is present or not, because that could downgrade the quality of your meta-analysis and the outcomes that are reported there. We talk about indirect evidence, so some things, again, that could lower your overall assessment of a type of evidence. Indirect evidence essentially means that the available evidence is not directly lining up with your clinical question of interest. So when we think about defining our research question, if we had a specific population in mind, say pediatric patients, and the studies we're finding, well, maybe there are some pediatric patients, but the most are adults, or perhaps most of the patients are 16, 17, kind of on the adolescent or older side of that pediatric age range. You might be finding an indirectness of really what you're looking for. You may also look at differences in either the intervention or the comparison. Perhaps dosing was different, or maybe it's really not a fair comparison of what's being studied. Or maybe there's differences in how the outcomes were measured. For imprecision, what we are trying to understand is how close the outcome saw in this study aligns with the ultimate true difference. And so you want to understand how well you are actually estimating the true treatment effect. You specifically do this by looking at whether or not you had a large enough sample size and whether or not you had enough events to capture a precise effect estimate. So when you're looking at that confidence interval, for example, if you see a very wide confidence interval, that may suggest you had too few patients. It may suggest you didn't really have enough events to drive that true treatment effect difference. And that may be a suggestion of imprecision. Another way, since assessing the wideness or narrowness of a confidence interval is difficult, is you can look at whether or not that confidence interval includes a clinically meaningful benefit. So while we may say a 1 millimeter reduction in mercury is really not that clinically meaningful on average to patients in a blood pressure trial, if our confidence interval suggested that there was a 10 millimeter mercury reduction in blood pressure, we may find that clinically meaningful. And so determining what is a threshold for a clinically meaningful difference can help you interpret those confidence interval and decide how precise or how significant some of these outcomes are. So finally, publication bias can be one way that decreases the quality of the evidence you're looking at. So publication bias occurs when studies with positive or statistically significant results are more likely to be published than studies with negative or non-significant results. This is especially important when you're numerically aggregating your data in a meta-analysis. You'll want to know how many studies were included and how large that effect size was. There are different types of statistical tests you can perform to detect publication bias. The most common method you'll see is a funnel plot that's often included in a meta-analysis. All right, so some factors that can increase the evidence quality. So those last 5 all were ways that you may see a decrease in evidence quality. Things that might increase that would be a large magnitude of treatment effect. So if you're seeing a significant treatment effect that largely outweighs any potential bias that may have resulted in an under effect, that may lead us to believe there really is a treatment difference here. Dose response can also give us sort of a plausible biological rationale for treatment. And so if we see an increasing response with increasing dose, that may be more supportive of an actual true treatment effect. It may also help us narrow down that treatment effect size. And then finally, the effect of plausible confounding factors. So again, if there are things that would lead you to believe the drug is not effective and the drug is still showing effectiveness, that could outweigh the potential concern or mitigate any concern that the drug was really not having a benefit. All right, so coming back to the grade system, the grade system is built upon two pieces. So there's a strong or a weak recommendation, that is 1 or 2, strength of recommendation. And this is followed by a letter, so A, B, C, or D. And that letter reflects the quality of information, where A is a recommendation based on the highest quality available data, and D is a recommendation based on lower quality data. So in summary, collecting large quantities of information without critically evaluating what it has to offer will not be helpful to you. I've seen teams with 150 plus references, but if they didn't understand or critique what's in those references, their recommendation was not any better than other teams with fewer references. In order to determine how valuable information is, you have to first determine what type of evidence you have. So there's different things we're looking for from an RCT versus meta-analysis versus a case series, and et cetera. And then the grade system, which we focused on in this module, is one example of a tool that can be used to evaluate the quality of literature in a systematic way to help you either compare and contrast or to aggregate that into a summary of your entire body of literature. And with that, we will close this second module. Again, resources for the competition, student membership, the foundation are available on this slide. We hope to see you for module 3.